Hi, my name is Dr. Megan Gilmore, and I am the bariatric surgeon at Mayo Clinic Health System in Mankato. Thank you for your interest in our surgery program. The purpose of this online informational session is to give you information about the history of weight, how it impacts our health, and some of the surgical treatments that are available. After you complete this online informational session, you will contact our office for a post-informational session quiz, paperwork for your health history, and an insurance form. In the United States, approximately 2/3 of adults are overweight and about 1/3 suffer from obesity. These rates have doubled over the last 20 to 25 years. What is even more alarming is that these rates have actually tripled in our adolescents. Here is a map from the CDC that shows the rates of obesity from 2011 to 2018. In medicine, we use numbers to define weight, just like we use numbers to define diabetes and hypertension. For weight, we use a number called a body mass index, which is a complicated formula that takes into consideration your height and weight. And then we get a 2-digit number, and this is how we define your weight from a medical standpoint. The reason this number is important when we are talking about bariatric surgery is because it is the number that insurance companies look at when they're deciding whether or not they will pay for bariatric surgery. We will come back to this in a little bit. We know that obesity is a very complex disease, and there is no one cause of the changes that we've seen over the last 25 years. Rather, it is a complex disease with many overlapping elements. We believe there are different factors contributing to weight for each patient, and so we take an individualized approach with a multidisciplinary team. Our weight has an impact on our health and has well-known association with things like diabetes and heart disease. But there are actually many other parts of our health that can be affected. There's a link to liver disease, infertility, sleep apnea, stroke, and even certain types of cancer. We believe that treating obesity will improve some of these problems for patients that are already suffering from these health conditions. But we also believe that will help prevent patients from developing these medical problems in the future. Our surgery team members consist of myself, the surgeon, Heidi Bernardchuk, our clinical nurse specialist, Sarah Baldwin, our certified bariatric nurse. Our team also consists of dietitians Grace Feldberg, Roxana Padilla, and Christy Wempen. Our psychologist is Bonnie Betts, and the physical therapists that work with our patients are Sung Won and Patty. We also have a team that works in Fairmont and includes dietitians, psychologists, and physical therapy. Our dietitians provide one-on-one individualized sessions. One of the benefits of working with a dietitian in this manner is that they can help you achieve your weight goals, but they can also address other medical problems that can be modified by diet. Our dietitians will help you develop strategies to improve your dietary habits. Our psychologists also offer one-on-one individual appointments to ensure that patients are psychologically and emotionally ready to proceed with surgery. One of the keys for maintaining weight loss in the long term is exercise. Our physical therapists will help our patients develop an exercise program that they can either do at home or in a gym. We do want patients exercising a minimum of 3 times per week before surgery. Our physical therapists will also help patients learn how to increase the intensity and frequency of their exercise. Returning to the BMI that I talked about earlier, technically, obesity is defined as having a BMI of 30 or more. Unfortunately, however, in Minnesota, there are no insurance companies that cover bariatric surgery for a BMI between 30 and 35. If your BMI is 35 or greater, you do have to have another medical condition that is related to your weight. If your BMI is 40 or more, you qualify for weight loss surgery based on your weight alone. I touched on some of the medical conditions that can be associated with obesity earlier. This slide is intended to demonstrate the degree to which those medical problems can improve following surgery. The most studied medical problem in relation to surgery is diabetes. Anywhere from 43 to 85% of patients will have their hemoglobin A1C return to normal while no longer requiring medications. Although this is a big range, factors such as how long a person has had diabetes and whether or not they use insulin will affect the outcomes after surgery. We also see improvements in fatty liver disease, sleep apnea, infertility, degenerative joint disease, and overall quality of life. The following is an overview of the requirements of our surgery program. The first step is completing an informational session, which this online session does fulfill. You will have a minimum of 4 visits with the dietitian and the psychologist. Our dietitians and psychologists may require additional visits if they do not feel that you're ready to proceed with surgery. Additionally, certain insurance companies do require that patients have additional visits with our team. You will have 2 visits with the physical therapist, and we do want you exercising 3 times a week prior to surgery. There are also individualized requirements based on people's medical history, including sleep studies, imaging of the stomach anatomy, and working with your primary care provider to make sure that your health problems are under good control. Some patients will also visit with the pharmacist prior to surgery to review home medications. Here in Mankato, we offer 2 surgeries, the gastric bypass and the sleeve gastrectomy. Here is a short animated depiction of the gastric bypass.
In Roux-en-Y gastric bypass, the surgeon creates a small pouch at the top of the stomach. The pouch is the only part of the stomach that receives food. This greatly limits the amount that you can comfortably eat and drink at one time. The small intestine is then cut a short distance below the main stomach and connected to the new pouch. Food flows directly from the pouch into this part of the intestine. The main part of the stomach, however, continues to make digestive juices. The portion of the intestine still attached to the main stomach is reattached farther down. This allows the digestive juices to flow to the small intestine. Because food now bypasses a portion of the small intestine, fewer nutrients and calories are absorbed.
The gastric bypass is the most common surgery that we perform in Mankato. It does have slightly better results in regards to weight loss and resolution of other medical problems. Here is a short animated depiction of the sleeve gastrectomy.
In a sleeve gastrectomy, part of the stomach is separated and removed from the body. The remaining section of the stomach is formed into a tube-like structure. This smaller stomach cannot hold as much food. It also produces less of the appetite-regulating hormone ghrelin, which may lessen your desire to eat. However, sleeve gastrectomy does not affect the absorption of calories and nutrients in the intestines.
Nationwide, the sleeve gastrectomy is the most popular bariatric procedure. With this procedure, we do not do any rerouting. However, about 75 to 80% of the stomach is removed. Following bariatric surgery, pregnancy should be avoided for 12 to 18 months. Patients who are currently suffering from infertility should be on reliable birth control, as infertility can resolve quickly following weight loss surgery. We also recommend no alcohol use for 1 year following surgery. You do need to quit smoking or using any nicotine products for 2 months prior to surgery, and you should be committed to not starting these products after surgery, as it can have devastating consequences on your surgery. Patients often ask if there is a reason that they cannot have surgery. If you are too sick to undergo general anesthesia, the surgery cannot be performed. If you have active addiction or uncontrolled psychiatric conditions, you do need to have 1 year of sobriety or 1 year of psychiatric stability prior to proceeding with surgery. We also will not perform surgery if you are actively smoking, and you do need to quit smoking 2 months prior to surgery. If patients have a condition called Barrett's esophagus, they cannot have a sleeve gastrectomy, but they are still candidates for a Roux-en-Y gastric bypass. As with any surgery, there is a risk of bleeding, infection, blood clots, and reactions to anesthesia. With the gastric bypass, there are specific complications that can occur, such as leak, strictures, ulcers, dumping syndrome, bowel obstruction, and vitamin deficiencies. The sleeve gastrectomy has similar risk to the gastric bypass. However, patients occasionally have issues with nausea and heartburn. Typically, these problems are controlled with medications. However, very rarely, patients have required conversion to gastric bypass. These risks will be discussed in more detail at your initial appointment, as well as at your preoperative appointment. The surgery is performed laparoscopically with small incisions. We usually use about 5 or 6 small incisions. Patients will be up walking on the night of surgery and typically stay in the hospital for 1 or 2 nights. They are sent home on a full liquid diet for 3 weeks, and they slowly advance their diet while working with their dietitian over the next couple months. We typically recommend 2 to 3 weeks off of work after surgery. Patients are usually recovered from a physical standpoint rather quickly. However, it is a big lifestyle adjustment. The big question that patients usually have is how much weight they can expect to lose after surgery. Again, we look at a complicated formula to figure out what your excess body weight is. Basically, this is any weight that is over your ideal body weight. With the gastric bypass, patients will lose about 70% of their excess body weight, and with a sleeve gastrectomy, they will lose about 60% of the excess body weight. If you are a woman who is 5'6" and weighs 280 pounds, you have a BMI of 45.2. Again, this is based on your height and your weight. Your ideal body weight is 130 pounds, and this is based on your height and your gender. Any weight that is over 130 pounds is considered excess body weight. This patient would have 150 pounds of excess body weight. If she had a gastric bypass, we would expect her to lose about 70% or 105 pounds. She would end up on average at about 175 pounds with a BMI of 28.3. If she had a sleeve gastrectomy, we would expect her to lose about 60% of her excess body weight or 90 pounds. On average, she would end up at about 190 pounds with a BMI of 30.7. If you are a man who is 6 foot tall and weighs 300 pounds, your BMI would be 40.7. Your BMI is based on your height and your weight. You would have an ideal body weight of 171 pounds. This is based on your gender and your height. So this patient would have 129 pounds of excess body weight. If he had a gastric bypass, we would expect him to lose about 70% of that excess body weight. This is about 90 pounds. On average, he would end up at about 210 pounds with a BMI of 28.4. If he had a sleeve gastrectomy, we would expect him to lose about 60% of the 129 pounds. This comes out to 78 pounds. He would end up at a weight of 220 pounds with a BMI of 30.2. Of course, these numbers are averages, and some patients lose more and some patients lose less. After you complete this online informational session, please contact our office. You will need to complete a post-informational quiz, fill out paperwork, and give us your insurance information. Once we have that information back from you, we will call you to set up an appointment with either myself or Heidi Bernardchuk. We look forward to working with you on this journey towards a healthier lifestyle.